But I want to, at this point, invite Prithvi back up. And Bertil, if you can come up as well. And Peter. And Michael Seider. So we have 4 ophthalmologists. And what we're going to do now is use this fun little thing called a catchbox. And this is actually a microphone. So we're going to kind of bounce this around. I'm not going to chuck this in anybody's face. But I want to have this be a free-form time for people to ask questions of our experts here. Is Michael here yet? Okay, this is fine. We have plenty of brain power up here between you. But one thing we always get is I wasn't given the chance to get genetic testing. Or I got it back when there weren't all these varied arrays of GEP results. What does that mean for me? So maybe we can, from the ophthalmologist perspective, give feedback to patients who maybe weren't even given the chance to do GEP.
I'm going to ask Bertil to address this because he's probably had the only because I think he's had probably the longest experience, maybe in the world, of offering genetic testing at an early stage. And I'm sure you get patients who come to you saying, "I was never offered this," and how do you approach that in your clinic?
Yes. Genetic testing has really transformed my experience with uveal melanoma. I've been doing it since 1999, offering it as a routine service to my patients. At first it was just with patients with big tumors, but as technology has improved, not just in the operating theater, but also in the laboratory, it's become possible to biopsy smaller and smaller and smaller tumors. So now it's possible to biopsy really small tumors. But a few years ago, it wasn't safe to do so. It wasn't possible to do so. And one encouraging thing is that the smaller the tumor, the smaller the effect of the genetic result. In other words, with big tumors, it makes a very big difference whether it's one type, genetic type, or another. With small tumors, it makes a small difference, at least in the first 10 years. We have to wait another 20, 30 years to have enough data to know. So if you haven't had a biopsy because you had a small tumor, it should be reassuring to know that it would have made a small difference in any case.
Anybody have a follow-up to that? Who wants to take the first lead? Here you go.
Dr. Damato, can you talk about doing genetic testing post-radiation? Because I know you've done that before.
Yes. Years ago, I got into trouble because a patient of mine got a vitreous hemorrhage. And I couldn't see what I was doing when I was putting in the markers for proton beam treatment or Clark treatment. And then there were also patients who were afraid that touching the tumor would spread it around the body and cause metastasis. And so it was obvious to me that the best thing to do was to start doing biopsy after the radiotherapy. And with the cytogenetic techniques we're using, or still using, it's been possible to do a biopsy after the radiotherapy, and the results seem to have been, so far, they seem to be just the same as if no radiation has been given. That's because although the radiation damages the DNA, it does so in a sort of, it creates a bit of noise, but if there's loss of chromosome 3 or gain of chromosome 8, that still remains there. It doesn't disappear. So as long as there's still tumor left, you can do the biopsy. Of course, if the tumor's atrophied completely, there's nothing to biopsy. With gene expression profiling, it's different because the technique is different. I don't know, I can't speak about this because we're still waiting for results, I understand. But I've a feeling, from what I've heard, that in time, research might show that the results are useful, but at the moment, it's a bit early to say that. But hopefully, It'll be the same as gene expression profiling, but we'll have to wait and see, I think. But I'm not the best person the best qualified person to speak about that.
I think one of the issues is, again, I don't think we have enough information that's been validated. So I wouldn't recommend everyone who hasn't had a biopsy running back tomorrow and saying, schedule me one for tomorrow. That may be helpful, but the question is the answer you're getting, are we sure that it's a true answer, or it may be modified from what the original was? I think that there may be advantages to chromosomal testing in that scenario versus gene expression, but I just don't think we have the answer on both platforms fully. But I think that it is being looked at, and I think we may learn more in a few years about the true applicability of it. But if you didn't have a biopsy, again, it doesn't mean that you're not going to be followed or you shouldn't have screening, because at this point, having that information may alter the frequency of the testing that you get done, but it doesn't eliminate the need in all cases for systemic testing in all patients. Peter, do you have any thoughts on how you manage that?
No, I think you can just look at the papers that have looked at the size of the original tumor, and you can calculate risk based on that without genetic testing. There's some pretty good models for that. So that's generally what we will adopt. Again, there's so many unknowns going forward, and the genetic testing, as we know, is not perfect. With the 1A testing, it's possible still to develop metastatic disease at a 2% rate. And so we're not sure why that is. People are looking at that. I think Bill Harbor's group at Castle is doing a good job at exploring that. But there's a lot of unknowns. And one thing I want to point out is doctors treat populations of patients, but for each patient, it's an individual experience. And for doctors, if I tell you your risk has been reduced from 20% to 18%, I don't know if that's going to make a difference. But for most patients, it's all or nothing, as you guys know. So we are on somewhat different sides on the fence on that issue. I think the information in general is useful, and we find about 95% of our patients do want genetic testing when they're offered it. But some patients choose not to, and we want to reassure them that's okay. And we will adopt, surveillance methodologies per their wishes. I think there's good evidence to suggest early detection is in fact helpful. That is debatable in the field. Some people think looking early doesn't help. But again, we're really using the genetics to modify our surveillance protocols. And ultimately, it's the surveillance protocol that's important to the individuals. But the genetics are important because they allow you to enter into these adjuvant trials that we've talked about somewhat.
Go ahead.
Dr. M mentioned radiopathy.
Retinopathy.
Retinopathy.
Yes.
Some of my contemporaries, including myself, at 2.5 to 4 years out, have started having problems with their eyes. In my case, myself, 4 different situations. And it's frustrating, and many of the patients have commented to me, well, if I had known I was going to be living with this with shots once a month, I would have opted for enucleation. And I understand there's no knowing how you're going to respond 2.5, 4 years down. But there's very little out there for patients to research or to understand. And there's many, many different, like there's 2 or 3 injections to the eye now. And there's cataracts, and it just goes on and on.
Correct. So the radiation treatments can do incredible things to kill the tumor within the eye, and that's awesome. That's the intention. But like with any treatment in medicine, there can be side effects, and some of the side effects that you're alluding to are things like cataracts or radiation retinopathy, in which the radiation damages not only the tumor but the healthy tissues surrounding it. And the ultimate effect is that it impacts vision in different ways. And before, there really weren't that many good options to try to control it or treat it. You'd kind of watch it, You might do some laser treatment, think about steroid injections, but now we have this new class of drugs that block the signals that cause a lot of leakage. It's the same drugs that we use as injections into the eye in diseases like diabetes or macular degeneration. So, your grandmother who has this is probably getting an injection every month for the past 3 to 5 years, every month, to try to keep their vision intact. So the burden of the injections are definitely something that we recognize in other diseases. The hard part about this disease is that unlike diabetes, radiation retinopathy can tend to be very rapid, very aggressive, and starts a few years after. So you're doing okay from vision, and then 2 to 3 years later, that's when things start to change. I think that we've seen incredible opportunities to make the retina look a lot better with these injections, but sometimes when the damage is done, it doesn't, it's still not recoverable completely. I think there's now a move, I think, within our community to start looking at different ways that we can understand this a little better, whether we can change the dosing that we use for radiation, whether we can look at the role of these injections up front rather than waiting for changes to occur. I would still say that, for most, even if the vision isn't good, having kept the eye in place is still important to many people. But I do understand, the burden that these injections involve.
I think there's a big blind spot with regards to radiation side effects. And in the 1980s, I had a patient with lots of yellow exudates affecting the vision. And I could see that they were all coming from the tumor. So the obvious thing to do was to remove the tumor. And I removed the tumor and all the exudates went away. And from that patient, I learned that you have 2 types of radiation complications. Those when you get collateral damage, when tissues are on the line of fire. For instance, if the optic nerve is right next to the tumor, or if the lens is in the way, you get a cataract, that kind of thing. But then you also have complications from what I've called the toxic tumor syndrome, that the radiation damages the arteries and veins inside the tumor, and so they get blocked. And so you get hormones inside the eye that stimulate new veins that block the gutter and cause glaucoma. Or else the veins, arteries and veins inside the tumor become leaky, and you get lots of fluid leaking, lots of fat leaking. And by either removing the tumor or by lasering it so that you shut down all those veins and you just end up with a scar that stops leaking, you can improve the vision and you can get rid of the problem. So it's a totally new philosophy, and a lot of people still don't believe that, the toxic tumor syndrome. But it can improve the situation when the injections fail or when other treatments don't succeed.
Well, as you know, in my case, I was 20/20 for 3.5 years. I had a very, very good team. But then I developed all these problems and massive hemorrhaging over the period of 1 year, and I had my compound vitrectomy, which was 4 different procedures and a cataract replacement on the way out. And now my eye is back to 20/30. Wow. So it can be done. I was lucky I had 20/20 vision going into the entire process of ocular melanoma. But I think I must have had toxic tumor syndrome.
Yeah, toxic tumor syndrome.
Question. I've got class 2, had it Castle tested, and done 3.5 years out from plaque therapy. And the first 2 years I was 20/20. Then I developed retinopathy from the radiation. And I'm currently in a clinical trial with Genentech's drug. I'm having a senior moment.
Lucentis, yeah.
Avastin. And have been doing that for a little over a year with shots every month except 2, with fluid keeping coming back. And it looks like I'm looking through a shower door with water on it. Got a few spots where I've wiped it off so I can see a little better. But Is laser therapy something that can help stop that leakage? As I understand, you're saying laser therapy is designed to stop that leakage that's causing the fluid to build up underneath the layers of the retina. Is that something I ought to be looking at now? Wait till the clinical trial's over?
I think it's a discussion you should have with your ocular oncologist. I had a patient just a couple of years ago, and she, as predicted, lost vision in her right eye because the tumor was just above the fovea, and all the fluid went straight to her central vision. And we tried everything, tried all sorts of injections, and nothing worked. But then we gave this laser treatment, transpupillary thermotherapy, which you heard about a few minutes ago. And one session was enough to bring her vision back to normal again. So it's something you should discuss with your ocular oncologist, the possibility of transpupillary thermotherapy to either ablate the tumor or to create a sort of raincoat, a waterproof scar over its surface to keep the fluid within it.
Okay, second question, I don't know if this is the appropriate time, but can we talk about Class 2 people and what's going on with clinical trials for adjuvant therapy for those who are in ED like myself, no evidence of disease, 3.5 years out?
I think we're going to hit that this afternoon.
Is that
Yeah, we have a full session on clinical
in the
trials.
afternoon.
okay?
Yeah.
Okay.
And also, we have a full session from Castle Bio over lunch. So once we get lunch, we can come back here and drill into the specifics of gene expression profile testing.
So just a really quick question. Dr. Peter talked about how those patients that didn't have the biopsy use the size of the tumor as an indicator. The question we have is, which one tends to be a greater indicator, the size of the tumor or the genetic testing?
I think that is the question out there right now. I don't think I have the answer. I
Come
do
on,
think
I'm just kidding.
I've heard, and I believe truly that as Bertil said here, in the large case, a large tumor can trump the genetics sometimes. I don't know if maybe I'm saying it opposite to what you said actually. But I think the 1A tumors that have developed metastatic disease tend to be larger and more anterior tumors. And so we haven't quite reconciled those two different models. It's easy to measure the tumor size. And so we're still looking at that. Bertil, I don't know, you have more thoughts on that?
If you only know the size, the bigger the tumor, the greater the chance of having a class 2 melanoma, a bad melanoma. And if there is a bad melanoma, the bigger the tumor, the longer it's been there, the longer the metastases have been growing, the shorter the lead time bias, the shorter the time before the metastases develop. So that's if you only know the tumor size. If you know the genetics, if it's a bad melanoma, as I've said, it makes a big difference to the life expectancy. If there's no lethal mutation and the tumor has no capacity to spread, then size doesn't matter at all. You can have very big tumors with no bad mutations, and you can have small mutations which have the mutations. So it seems that metastatic disease develops almost exclusively in patients who've got a class 2 or a monosomy 3 melanoma. And if you don't have those things, then you don't have a risk of melanoma. And if you get metastasis, and if you get metastasis, it means despite having a good melanoma, it's because the techniques have failed to detect the lethal mutation.
If the testing mechanism is accurate and good technique, the prospective data and larger studies that are retrospective suggest that genetic information probably trumps clinical information if you had to choose one over the other. But I think what we're all saying is that it's all in context. It's in context of what you see. And you may get a result, but clinically, as the clinician, you are going to interpret that, with a patient in front of you, not necessarily what the papers tell you.
So just to clarify that, I'm PRAME positive and class 2, but I have small to medium. So
Right. So,
I'm just
right. So, what she's discussing is that there is the class 2 designation, but then now a newer piece of information that's come about is the presence or absence of PRAME, which is another antigen that's been identified and might be modifying the risk. What it seems to tell us is that PRAME is a modifier to make class 1 tumors more aggressive than not, and we think that PRAME still adds some level of activity to the class 2, but class 2 is still class 2.
But it doesn't change class 2 that much?
Well, we don't have prospective data to validate that, and there's currently a clinical trial that several of us are involved in, which is the COOG-2 study that's looking at that prospectively. So we're collecting information right now and looking at those mutations in that setting. So there's some data, but it's not the robust data that we need. And that's the problem, is that these are new mutations that are being identified, but in order to study them, we need patience and time and to be able to see where that goes. So it would just mean, for me, clinically, that if you're class 2 and PRAME positive, you are someone that would need to be followed very closely to be able to know, how that PRAME modifies your risk. It doesn't change anything else except that you just watch closely.
Dr. Peter, just carrying on.
I was diagnosed May 17th of 2016 with I'm on state Medicaid, Missouri. They only allow an eye exam every 2 years. In 2014, I was clear. I'm an advocate for dilation. So when I came into my optometrist to get my eyes examined in 2016, I was not expecting anything. I was having some curtain vision, but I thought it was an infection or something. A couple of drops and it cleared up. So imagine my surprise when my optometrist sends me over to a retina specialist. And I'm like, scared to death, On May 17th, which was my mother's 71st birthday, I'm told I have a tumor in my eye, and it's cancerous. They said, that the doctors diagnosed me, as soon as he found out I was on Medicaid, said, oh, I can't do anything. Getting over here. So I found out at KC we had nobody. No surgeon, nobody. Treats us. Luckily, they had just left before got Dr. Seider in. Dr. Seider did a brief scanning. Said I had, at that time, a 15 millimeter by 10 millimeter thick tumor, and advocated full removal. That everything was good. Did the removal on June 23rd. I thought I was clear. She thought I was clear. Pathology report said no retina tearing, the tumor had mushroomed, and it did not connect to the optic nerve. Had no indication whatsoever that any future trouble. So, she thought maybe best had 5 years. I went in January 23rd this year. They found 3 tumors in my liver. There were not tumors in July. So 6 months later, I metastasized. I've tried for years. They found that my tumors are growing. The radiation didn't work. Immunization didn't work. I just found out I'm also alpha-1 deficient. I don't know, most of you probably never heard of it. It is the enzyme that protects the liver and lungs from disease and cancer and helps it regenerate. Because I'm moderately deficient, one of those areas is the enzyme. Are you guys in your genetic testing? I was never offered genetic testing because Medicaid doesn't pay for it. So I don't know anything about that. But what about this other stuff? I personally think alpha-1 should be tested on this, with this, because if it's missing in one of these areas.
So the question is just, should we start to ask for
Yeah, and
alpha-1
why are you guys testing for it? What can someone like me do now? Because I don't want to die, but until I have maybe another 6 months, I won't see, there's something I probably won't see my 50th birthday. You know, I want to live. You know, I got the only doctor I got that treats me like a lab rat. I'm not a lab rat. I'm not the disease. I am a person who say, I want to live. And nobody in my area is saying, you know, doesn't see it out there. What can you guys tell me that's, you know, will help give me some encouragement? Thank you.
Thanks for sharing. There's a lot of people here who I'm sure feel the way you do as well. And we don't have all the answers, I'm afraid. We don't. The alpha-1, I assume it's alpha-1 chymotrypsin enzyme.
Yeah.
And I don't believe that's a standard part of screening.
Why not?
Well, I don't know, but you're raising a good question there. But let me go back to one thing, if I can, just to go through your personal history there of the being found to be clean, your eye was removed, the tumor was gone. That's a limitation of the screening tests that are done, the MRIs, the PET CTs. They can only detect tumors that are of a certain size. And if they're smaller than that, they can't see them. There's no doubt on your history that probably the day you were first diagnosed that there were cells in your liver already. They just couldn't be picked up with conventional screening. And you know, just the way I like to think of it is if you have a certain kind of tumor, probably the class 2, it can flow into your bloodstream and distribute itself throughout your body. And when it hits the liver, it's like a Velcro ball sticking to the liver. This is where the adjuvant trials come into play. This is the approach that doctors are trying now, is to identify those patients that have that situation going on, and then before those cells gain the ability to grow, attack those cells, or unleash the immune system to attack the cells. So that's why we think the genetic testing is very important. Now, based on your size, we would have put you in a high-risk group alone without the genetic testing. So I'm afraid I don't have answers, and this is why, you know, doctors are people too, and they're sensitive. And I've heard doctors say in the past, famous doctors, I don't want to do genetic testing because I don't know what to tell my patients if they're class 2. We don't have a cure for that. So this is why an advocacy group like OMF is so important. You guys can get the information, you understand where the limits of our knowledge are, and you can ask for more trials. And I think the adjuvant trials are the key things right now, because you need to interrupt that step. They have to gain some function, most likely, to become tumors in the liver.
So I'm not even being offered any trials. Nobody's talking to me. I know nothing, you know, about what's out there, because doctors in my area know nothing.
I'm going to hand off to Bertil.
What I will say is, and I think this afternoon will be really instructive for everyone, because we're going to be talking about all the major trials that are available, and then I think we could even chat, you know, offline about how to gain access to some of these in terms of, you know, what's available, and then try to connect. So I think that's an important part of why we're here today.
So we have one question with the catch box, and then one short question after that. I would also remind you, these guys are here all day, and we also have a session this afternoon from 2 to 3:30 that's going to allow you to take these really personalized questions, go into the breakout rooms, and have direct interaction with them, because everyone's case is unique. I think having that one-on-one conversation with these experts will be a key piece of that. But let's start out with the question with the...
Two quick questions.
Yeah.
Dr. Peter, you mentioned that there are models out there that we can take a look at in terms of size of tumor. Where can we find those models? And number 2, how long can you continue Avastin injections safely? Do they go on forever?
There's probably a variety of models. I think Bertil has his own model. It's Bertil, do you have, yours will predict with just size without the genetics, won't it?
Yeah, the model I've developed with data from about 4,000 patients that I've treated over the years is called ocularmelanomaonline.org, one word. I'm sorry, I didn't choose the... If you write ocularmelanomaonline.org, then you'll find it, and you put in your age, your gender, tumor size, and if that's all you have, it'll predict according to that. If you also have genetic data, then you add that and you'll get your result.
The second part they've asked, and we know from our patients with macular degeneration that you can do it. It appears to be indefinitely. I have my longest standing patient has been getting monthly shots for 12 years. And she's a retired nurse who assisted eye surgery her whole career before retiring. You'd think there would be some kind of good karma for her.
Does she have her own parking spot in your office?
She does. She has her own chair.
Very nice.
But she is able to read 20/50 out of her good eye and understands. Some people are in that limbo. And to answer your question, sir, I think it's customized for everyone. The location of the tumor, the size of the tumor, the radiation effect on local structures is really different for everybody. And it is difficult to think you have to work so hard to maintain your vision undergoing surgery. And I think our technologies have brought us to this level where we're doing things we've never done before. And we're able somehow to extend the game. We keep playing it out further and further. But to note, there were studies in the COMS study, which was an older, very large study that established radiation treatment as an effective treatment for melanoma, that showed that patients, in terms of quality of life, apparently would have an equal quality of life whether their eye was removed or whether it was treated with radiation. And I don't know if that's true today with our modern techniques that we have, but I think fundamentally it's about quality of life. I had a patient that had been treated with radiation 15 years ago. I met her in my practice. And as I was leaving the room, I said, by the way, how's your eye doing? And she says, oh, it bugs me every day. It's just really painful. She didn't see. And her tumor was well treated. She's a survivor, doing very well. And I said, well, let's remove that eye then. And we did, and it took care of her problem of chronic pain. So everyone has different solutions. You can always be enucleated later. I'm not suggesting you guys all go do that. But it's about the quality of life. Is it anxiety? Is it pain? Is it disfigurement? Those are important issues every step of the way.
That's what I'll be speaking about in a few minutes.
Good lead in. I apologize. We have a bunch more questions. We're going to take one more, and then we're going to move to Bertil's talk because we're already running behind. But again, these folks are all going to be here, and they can speak later this afternoon from 2 to 3:30.
So I have a question about hereditary and genetics, because up to this point I wasn't actually very concerned about having my children more aggressively tested. But after talking to a couple people who actually may have some kind of hereditary link, I was curious to know if we should be doing anything different with our own children.
It's a really good question, and again, we've learned so much more recently than we've known before. We do have a session this afternoon with one of our Stanford cancer geneticists, so that's a great time to delve into that. I think the bottom line is that we now know that there are some cancer predisposition syndromes that are associated with development of ocular melanoma. These are individuals that have a family history of multiple kind of strange cancers like mesotheliomas, other types of tumors that may have this predisposition, and testing for BAP1, which is a mutation that you can find in the blood, might give you a clue that others in the family may develop these. Now, there are not a lot of families, several dozen maybe, that have been identified, so it's not common. And we don't think that everyone that has ocular melanoma necessarily needs to have that testing unless there is a family history that would dictate it. So we're not saying that everyone should go get that done. Probably most important is to be sure that if there's a strong family history of cancer, that your family members make sure that they have their colonoscopies and their mammograms and that type of thing for general health. And then from the eye standpoint, eye exams. And finally, if there is this strong concern about it, then talking to a genetic counselor or a cancer geneticist may help you to determine if that test is needed. Because you're probably going to do a lot more tests that are negative than are going to be positive, and so you don't want to necessarily over-test. So in general, but yeah, don't right. So we'll be talking about that this afternoon.
Thank you.
Yeah,
Thank
Peter Livonian is speaking this afternoon in the breakout room on genetic disposition. And just my little pitch, encourage everyone to get their yearly fully dilated exams. As someone whose father had a uveal melanoma, I tell everyone far and wide, go in, see an ophthalmologist, get a dilated exam. Tell everyone you know to do that. But join me in thanking all the doctors. Again, they'll be here this afternoon.